in newly diagnosed multiple myeloma, the greatest number of patients that are diagnosed with myeloma are between 65 and 79 years old. So it is very important to continue the progresses we've made in that population. The most recent progress we've made, which has become the standard of care for that population, is the implementation of the triplet-based regimen called MAIA. In other words, the combination of CD38 immunotherapy, daratumumab plus lenalidomide and dexamethasone. And in my daily practice, this is a regimen I'm giving to all my patients in that age population. Now, because the results of MAIA are incredible, approximately 31% of the patients MRD negativity rate at 10 to minus 5 threshold, with a median PFS around 5 years, 62 months, we thought that if we could improve the MRD negativity rate in that population, we could potentially improve even further the median PFS. And for these patients that are elderly, who knows, maybe they could live with only one line and sort of potentially get cured with myeloma, no relapse. So we've run this phase 3 study, BENEFIT, randomized 1-to-1 between a control arm with the new CD38 immunotherapy Isatuximab plus lenalidomide dexamethasone, sort of the MAIA regimen, but with Isatuximab, to Isatuximab, lenalidomide dexamethasone plus Bortezomib. Bortezomib is a proteasome inhibitor. We know how to use it. We've been using it for years. We know it's very effective in myeloma, and we know how to control and manage the safety profile of the Bortezomib. We gave it actually weekly for 12 months, 1/8/15, and then from cycle 12 to cycle 13 to cycle 18, the primary endpoint, time point, it was given 1/15, so twice every month, twice per cycle. Primary endpoint was the MRD negativity rate at 18 months at 10 to minus 5, done by NGS or flow if NGS failed. The results are not only positive, but also, I would say, I think we could say groundbreaking, unprecedented, because the MRD negative rate in 10 to minus 5 in the ISA-Lendex arm is approximately 26%, what was expected from the MAIA. However, in the other arm, in the quadruplet-based arm, it was more than 50, 53, 54%. And this was much higher than we initially thought when we launched the study. The survival is immature, so it's too early to see if there is a correlation between MRD negativity rate and survival, although we do expect that in the future. The safety profile is, of course, slightly, I don't want to say worse, but not as good when you add Bortezomib. However, mainly grade 1 and grade 2 neurotoxicity, not much in terms of grade 3 or worse. And so globally, if you think about the balanced benefits risk that drives our practice, the addition of Velcade, Bortezomib versus the safety profile was, I think, really in favor of the activity of the drug and not an issue with the safety profile. So I do believe that in the end, that phase 3, along with the IMROS phase 3 study for registration, will consider this quadruplet-based regimen Isatuximab, Bortezomib, lenalidomide, and dexamethasone, a new standard of care for these newly diagnosed multiple myeloma, transplant-ineligible patients, but sort of fit, non-frail, from 65 to 79, and I would say, objectively, should replace the MAIA old triplet Dara-Lendex standard of care.